Good afternoon, good morning. Dr. Jigar Patel. I've been at Oracle, formerly Cerner, for 17 plus years.
That's a long time. Sorry.
I joke with people, I have the long view on things now. Yes. It's kind of funny. Yeah. But I've done from a clinical perspective, I'm a clinician at heart. I've done most aspects of the product lifecycle from a client perspective, from an Oracle Health perspective.
Mm.
That's everything from sales to implementation, consulting, ongoing client relationship, and most recently product management. So I've gotten around the block a little bit on all the different aspects of the business that we have.
Yes.
So I bring a broad view of the world as well, having helped clients implement software, having helped develop software now, having sold software.
Mm-hmm.
So a little bit of everything across the board. Background clinically is pathology. Transfusion medicine was my subspecialty.
Yeah.
So I'm also a little odd in that space as well, because most of the folks that do jobs like I come from primary care or emergency department or hospitalist medicine. So also a little bit of an oddball that way.
No, that brings a good perspective. I'm gonna hazard a guess and say that there's probably been a little bit of change in that 17 years of your time working with Cerner to Oracle Health now.
Yes.
And I guess the hot topics now, that we're all discussing HIMSS, these have been front of mind in some of your discussions. Is that right? You've had a couple of sessions that you've been moderating.
That's
correct. Yeah. Tell me about some of the key kind of themes that you've seen come out of HIMSS.
So yesterday I moderated a panel where we brought some folks together and talked about interoperability and the implications of AI on interoperability. And how do you think about AI helping and assisting in that way? And it's really, I think the conversation boils down to it's a front end thing as well as a back end thing, in that AI will help inform better exchange. The data will be more relevant when you exchange it, easier to consume. But then also, once you get the data, how do you consume it in a different way to surface it to clinicians? So a lot of the interoperability space over my career has been about standards. And those standards build you into, or box you into standard formats and those sorts of things. And one thing we've seen here in the United States is a general distaste or dislike for the format because it doesn't tell a story. So from a clinical perspective, you've got great data, but it doesn't tell a story. So on the consumption side of that data, how do I potentially take that and turn it into a story so a human clinician can relate to it and understand the patient better as well? So it's an interesting way of thinking interoperability, because interoperability is fundamentally an exchange of data. But then how do I format and send out and then consume that data can be radically transformed with AI?
Yeah. And if I think about it, so if we're spending all this time and effort, resources and brain power on, let's make all the data really interoperable, like if the end goal was just to make it much faster to bill for healthcare, that's kind of, we're missing a lot of the point. We hope that a lot of the reason that we're doing this is for a lot of other reasons.
That's correct. And I think that the one connection I think people don't make sometimes between the data and the patient and finances is the story helps you accurately assess what is the work I'm doing as a clinician worth. So the creation of this is a more complicated condition than this is what we learn in medical school, but AI and other technologies can help you condense that in a way to say, oh, this is that nugget that can justify better compensation, especially here in the United States where we do fee-for-service. The diagnosis is everything, and how well you code it ends up with the financial implication.
Yeah.
Governments have done similar sorts of things. And they've used various proxies. In the United States, we use a note as a concept for how in-depth or how sick or how much time did you need to spend with this patient. It's based on what you've written in a note.
Yeah.
But over time, it could be just the data doing it.
Interesting. And so, you kind of touched a little bit on you'd hope that the data then would help clinicians to understand the story a little bit more for a patient, which could then result in hopefully better patient outcomes.
Right.
But there's impact internally for the clinicians as well, on because we also talk about workforce burnout and efficiencies within the system. So there's got to be positive implications there too.
Yeah, absolutely. And we have done as a person that's worked with electronic health records my entire career, we've done as much as we can with the technologies we had to surface data, but it has become overwhelming. And part of the burnout that you blame from an EHR perspective is how do I find all the right information? The chart review time is substantive in having to hunt and pack and find that information. While it's more accessible than ever before, it is also extra work to go do, and it causes that burden. Not just from a time perspective, but from a cognition perspective. We've done some recent prototyping where we're saying, okay, if I asked AI, summarize a patient's diabetic condition for me, that AI could take 15 seconds to spit back a narrative, relevant data elements very quickly and easily. If I had to do that in a traditional electronic health record, it could take 18, 20, 25 clicks and could take 90 seconds, 2 minutes to put that whole story together. And that's if you're a super user, you know the record really well and you know where the data is. But often you don't know where the data is because it's buried in some consultant's note from 3 years ago.
Yeah.
But AI can find that very quickly and make it easy. So I think we're on the cusp of having technologies that can actually reduce burden. We always thought we were reducing burden by giving more information.
Yeah.
That's actually inaccurate. And I think we're coming to that realization that's inaccurate. And so now we have technologies that might actually make that better.
Yeah, you've alluded a couple of times to, these technologies becoming available, and I guess I'm going to guess that it's a bit of a convergence of, some exciting change for Cerner now Oracle Health, but also just in the macro environment of technologies being available. How do you see that convergence then and the opportunity to utilize some of these emerging technologies to really kind of lift the game and meet some of those objectives we've been talking about?
Yeah, there is going to be some fundamental redesign of the things we've done in the past. The legacy ideas of how we present data, the legacy ideas of how do we structure data. We've gotten to enough compute power where do we really need to structure data at all? Because I can extract from unstructured in real time almost without a problem. So it begs the question that we've tried to structure and create relational databases over my career, and we could ask the question, do we need to at all anymore? I can actually get it from all these various sources and use technology to tell a story. Yeah. So we do have to rethink a fair amount, and that's going to be uneasy for technologists that have been working in this space for a really long time. Clinicians are actually probably going to be really happy about it because they're less focused on the technology. They're more focused on the story, the care, the how do I help this person feel better, et cetera.
Yeah. How do you think about then this important, exciting need to think strategically and redesign and everything? But there's also a lot of hospitals that are using it on a day-to-day now, and there's things that got to happen yesterday.
Yeah.
They're two quite very different vehicles to drive.
Yeah, they are different vehicles. And so you've asked a very good question in that how do I ease the burden of clinicians' movement from current state to a future state? One of the strategies we're taking is fundamentally don't change the data model, change the user experience. So if I don't monkey with potentially a less than optimal data model, if I don't mess with it but understand it and redesign the user experience, I can actually move faster potentially on how do clinicians get relief from the burden of the cognition that goes with it, but also the time.
Yeah, and I guess wherever possible, where the technology can work behind the scenes or not get in the way, and if anything, allow the clinician to do more patient-facing time. And that's, I think, where we speak about, not messing with the workflow and all of that. And they're all really important things. So that's great that it's front of mind. Thinking then, we've talked about what's happened to this point and what's happening right now. Where do you see then the exciting opportunities in the future? We've touched a lot on interoperability and AI and that combination of both. And then what to now? What can we look forward to seeing?
It's not a great technology answer. It gets back to the we've got technology that's advanced enough to make the technology invisible.
Yes.
An example is the product I get to work on every day, Oracle Health Clinical Digital Assistant. You basically put your phone on the table, it listens to your conversation, and it helps you create a note. And then it has all the great downstream effects of codifying data and other things that can help with interoperability, but then also satisfy regulatory, statutory, safety, quality needs in a way that, but I get to have a human conversation because fundamentally, patients they're in some of the most vulnerable moments of their life when they're sharing information with a clinician. And when they do that, we owe it to them to pay attention to that. And that return to humanity is an interesting evolution of the technology getting so much better. So the evolution of the technology is going to lead to a de-evolution of the practice, because the practice is going to go backwards in that now we're focusing on the patient, the interaction, and not worried about the technology. And
absolutely. And actually, final question. You've probably attended a few HIMSS in your time, then I'm going to imagine, and we're HIMSS 24. Anything you'll take away from this one that might be a little bit different, or at least provide you some reassurance or excitement about the future?
You're right. I've been to, I think, 15 of these
That's a few point. Yeah.
And I, after a while, they're all very similar. They're all very similar. There's ginormous booths everywhere and exhibit space and those sorts of things. I do think, and every year has a hot topic. You've done enough of these now too, that every year there's a hot topic.
Yeah.
And the hot topic kind of, it's a carousel and it goes in. The one thing I think that we're going to see more of is collaboration across companies. And one of the things we talk a lot about is multi-cloud environments. And how does a client decide what cloud to use? Well, we believe use whatever cloud you want, or use parts of whatever cloud you want, and use the best of what you decide. So for a long time in the electronic medical record space, it was all about everything in one place. But technology is also moving us backwards in that way, in that the technology is good enough and the APIs are available that I don't have to think about them sometimes. That I can move data, and it gets to interoperability as well. That interoperability becomes even more easy as well. So my takeaway is, I think, and the thing I'm going to take away from this is, I think this is, for me, it's going to be a little bit of a HIMSS where I think about how collaboration among companies and collaboration with clients that may use my electronic medical record or not is going to be different, and it's going to change over time. So that's what I'm going to take away from this.